Good morning, everyone. Welcome to Cases from the Community. Investigators discuss available research guiding the care of patients with endometrial cancer. This is part 2 of a 2-part CMA symposium held in conjunction with the SGO this year. I am your moderator, Shannon Westin. I'm professor and GYN oncologist at the University of Texas MD Anderson Cancer Center. I'm so thrilled that you all are joining us today. And I think it's because of these amazing gentlemen next to me. We have an amazing panel today that's going to move through these cases. So I'm going to just start immediately to my right. Dr. Brian Slomovitz, who's professor of OBGYN at Florida International University, the director of gynecologic oncology, co-chair of the Cancer Research Committee at Mount Sinai Medical Center in Miami, Florida. Welcome, Dr. Slomovitz.
Thank you very much, Shannon. Thank you for having me.
Of course. And Dr. Robert Coleman, Chief Medical Officer, Sarah Cannon Research Institute, Gynecologic Oncology at the Woodlands, Texas. Welcome, Dr. Coleman.
Thank you.
And then, of course, Dr. Matt Powell, Professor, Department of Obstetrics and Gynecology, Washington University School of Medicine, St. Louis, Missouri.
Thank you, Dr. Westin, for having me.
Yes, and it's a very distinguished panel. These are the people that are doing the work that you're going to be talking about today, the cases we're going to be discussing. These guys are changing the standard of care, and they're doing the work. Of course, with that come disclosures, so please note them. Moving through all the faculty here. Okay. So let's get started. We're very excited to cover a number of different modules that will be relevant to your practice. So we'll kick it off. Here's our agenda. Module 1 is going to be checkpoint inhibitors for MSI-high, led by Dr. Powell. And then we'll talk about microsatellite stable or mismatch repair proficient endometrial cancer with Dr. Coleman. I'll cover adverse events with immune checkpoint inhibitors alone and in combination. And then Dr. Slomovitz will bring us home with investigational agents and strategies. And then, of course, we're very grateful to the clinicians who provided the cases. These are all people out in the community who are taking care of patients and asking really relevant clinical questions to your practice. So first is Module 1, immune checkpoint inhibitors for patients with microsatellite instability high endometrial cancer. And this is our case presentation of a 60-year-old woman with MSI-high recurrent endometrioid adenocarcinoma of the uterus, status post-progression after minimal response to chemo.
Good afternoon, everyone. I'm Neil Love from Research to Practice, and welcome to our real-world case library, today featuring patients with endometrial cancer. We met with a number of community-based gynecologic oncologists to gather cases from their practices. Our first patient was presented by Dr. Lyndsay J Willmott, a 60-year-old woman who had a total robotic hysterectomy and bilateral salpingo-oophorectomy and pelvic node dissection for Stage IA, Grade 1 endometrioid adenocarcinoma of the uterus, and then was lost to follow-up for 3 years when she presented with abdominal pain and multiple peritoneal nodules that on biopsy proved to be recurrent disease. Carboplatin paclitaxel was administered, but quickly led to disease progression.
She had tumor testing, which revealed that she was mismatch repair deficient. So she was subsequently started on pembrolizumab monotherapy, and interval imaging revealed that she had resolution of her disease. So she completed 2 years of therapy, and her end of treatment scan was without evidence of disease, and she now continues in surveillance, and she's doing well.
Any autoimmune issues along the way?
This patient did develop hypothyroidism, which responded well to thyroid replacement. But otherwise, she did not have any significant toxicities related to her treatment.
Any questions for the faculty?
This patient actually had tremendous response to her checkpoint inhibition and had no evidence of disease. But I'm curious, for those women who have had partial response to therapy, are you stopping the pembrolizumab at 2 years? Or are you considering continuing the checkpoint inhibitor beyond that? There are some trials that are looking at the use of ctDNA. Would you consider utilizing ctDNA at the conclusion of this patient's therapy?
This case brings up a number of discussion points, including optimal first-line treatment of metastatic MSI-high disease and whether immunotherapy should be given prior to or with chemotherapy. Another question is optimal first-line immunotherapy in these patients, including the potential role of anti-CTLA-4 treatment in combination with anti-PD-1 antibodies, or the use of an anti-PD-1 antibody and a TKI, for example, pembrolizumab lenvatinib. Also, in anticipation of the upcoming discussion later on in this program of toxicity of checkpoint inhibitors, your experience with thyroid abnormalities, how you screen for these potential autoimmune complications, and how long you screen patients.
Okay, so let's hear it, guys. I think, we all love when we are able to treat a patient with MSI-high disease with a clearly targeted immunotherapy. But what do you do when you get to that response at the end of 2 years? I think CR is a little bit more straightforward. But Dr. Powell, what do you consider if you've got a patient with partial response?
Yeah, I'm glad you think that's straightforward because my patients, we sit and have a long debate about how long they should stay on, and especially with partial response, we don't really know, we don't have trials to really guide us yet on when we can stop, and really is that shared decision making with our patient on deciding. I would say most of the time my patients are continuing on therapy when they still have active disease.
Okay. What about you, Dr. Slomovitz? Anything different around that?
Yeah, no, I agree with Matt. It's tough to say. Right now, we don't know when to continue it or when to stop. I do, in the future, there's going to be some trials that looking at checkpoint in combination with other agents, even to overcome the checkpoint resistance, I would say, with perhaps a TIGIT or some other antibody in combination. So we'll have to see.
Yeah, and that's going to be part of clinical trial. I think in practice for now, single agent seems to be the way to go. But what about ctDNA? That's a hot topic. There was a whole session on it today. Dr. Coleman, are you using ctDNA to guide therapy for your patients?
Right now, I don't use it to guide therapy. I think it's still in experimental use. I don't know exactly what to do with the results, to be honest with you. And it does carry some prognostic implication. We know that from in the postoperative setting. But how we're using it to follow patients, and if we don't see resolution, is what do we do next? So, and I think so. It's still, fortunately, it's embedded in most of our clinical trials, and we'll have more information as time goes forward.
Yeah, this session here, I think it is still very exploratory, but certainly the results are very intriguing, similar to what we've seen in other solid tumors, where we see a nice fall that could be potentially associated with response and could potentially guide therapy, but a little too soon to tell, I would say. And then, Brian, you mentioned dual checkpoint. Are you using that outside of clinical trial ever?
Yeah, right now, I am not using it outside of the clinical trial. But we'll hopefully see in the near future some activity there. There was some data presented at the IGCS looking at atezolizumab and Bev by Katie Moore and Dr. Phu and their group, and there seems to be some early signal there, so we have to further evaluate that.
It's certainly very intriguing. And then just to cover Dr. Willmott's last question briefly, we are going to have a whole section on adverse events that yours truly will give a lecture on. But, thyroid abnormalities, the standard of care is to be checking for these aberrations in the labs, because rarely are these patients going to be symptomatic, and so you should be frequently checking and act accordingly. And then I think I speak for the group here that we like to use a multidisciplinary team, and we certainly want to move along and encourage that participation from an endocrinologist and ensure the patient's getting the best therapy. Okay, so let's see the second. This is Dr. Schneider presenting a 51-year-old with MSI-high endometrial cancer, status post-rapid, highly symptomatic progressive disease on chemo.
The next case is presented by Dr. Kellie Schneider, a 51-year-old woman who presented with a 5-year history of dysfunctional uterine bleeding, which led to a diagnostic workup.
As you can see, significant myometrial involvement involving the cervix, upper vagina, and parametria. And biopsy proved that this was a poorly differentiated endometrial adenocarcinoma. Started Taxol and carboplatin. Unfortunately, her CT scan after cycle 3 showed progression, and she was getting progressively sicker. We sent her tumor off for microsatellite testing, and it was microsatellite unstable, or MSI-high. I did start immunotherapy. She had significant improvement in all of her lesions, to the point actually where all of her disease resolved with the exception of a small amount in the adrenal gland and still some in her uterus. I mean, I'm not exaggerating when this patient was 3 weeks away from hospice, to the point where our chemo nurses were concerned that we were treating her. And she immediately, went to living a very productive life, traveling, completely asymptomatic. That was the sickest I've ever seen a patient come back with therapy. It really bought her a good disease-free interval where she felt well and was able to do a lot of things. She started progressing right at 2 years.
This case brings up the issue of second-line treatment for patients with MSI-high endometrial cancer in a patient with prior chemotherapy and a good response to immunotherapy. Would you consider combination immunotherapy, for example, ipilimumab and nivolumab in this situation? Does the patient's prior response to treatment affect your approach? What about the TMB or PD-L1 levels? How much additional toxicity is likely from combination immunotherapy? And are there interesting clinical trials in this situation?
So this is what we want to see, right? We have a patient that had progression of disease and then has a brilliant response. I don't know if you all heard, 3 weeks away from hospice. I mean, that's when you feel like you've really had a success. But of course, sometimes things don't work as long as we like. So I think a question that always comes up in our practice, and I'd be really interested to hear the panel's conversation around this, is do you use Len-Pem after progression on single agent checkpoint? Or do we have data for that? Dr. Coleman, do you do this?
Yeah, we have tons of data. Oh my gosh.
It's a data-free zone.
Randomized prospective data. Yeah, I was informed by that. Yeah. Yeah, no, I've heard, and not had this happen to me personally, but I've heard of people that have added it because of the potential interaction we've seen in an MMR-P space and have seen responses. I think obviously this is a great space for clinical trials and dual therapy, although we kind of focus a lot on CTLA-4. There may be actually, it may be even more promising activity with anti-LAG or anti-TIM3 that are coming. So yeah, this is the area where we really need to do clinical trial work.
Yeah, Dr. Slomovitz?
You know, I like that Rob sort of set me up there. We do have a trial, GOG 3038, Podium 204. Arm E, I believe, is in patients with checkpoint who failed. This patient, giving them the Insight asset checkpoint with anti-TIM lag. So we're really excited about that data. I think that's potentially a game changer, and I'm happy to discuss that further when we're done.
And I think GY025 also is trying
Correct.
to look at reinduction after time off to single agent immune checkpoint versus the combo of CTLA-4 PD-1.
So these are great opportunities for you to participate in these clinical trials and help answer this important question for these patients. What about what Dr. Love was saying around TMB and PD-L1? Dr. Powell, do you ever use those to guide immunotherapy strategies for endometrial cancer?
Yeah, certainly getting at, why is this patient mismatch repair deficient? Was it due to promoter methylation of MLH1, or was one of the other somatic mutations, or even perhaps Lynch syndrome, may have an impact on how they respond? Now, this patient had an excellent response, but unfortunately it didn't lead to the pretty long durability, 2 years, but now we're getting used to curing these patients, and it's so exciting time. But understanding these resistant mechanisms is really part of the next step, and as you mentioned, if that patient has that promoter methylation, maybe that is something we need to target early for dual therapy. And GY025 is one of those options as mentioned, and the lenvatinib pembrolizumab combination, although again, that's outside the label currently, but it's being investigated.
Yeah. And then what else? So if we're not going to go outside the label, what else would you do? Say this patient didn't have a clinical trial opportunity. Dr. Slomovitz, what would you be thinking of next for this patient?
Yeah, no, thank you for that. At some point in her care, I would have done next generation sequencing, really to look for another target. We do have an exciting trial, and I'll get into this later in my talk, but we have an exciting trial for the NRG, GY026, in those patients with HER2 amplification or overexpression to evaluate that asset. Actually, that's earlier on, but I think later on we're going to be looking at some of the other novel therapies. We know at ASCO last year there was ESMO last year there was a Destiny trial in breast. There may be an opportunity there to investigate in this disease as well.
Any other targets that you're excited about, Rob?
I think the ADCs are this is the next kind of big thing for us, and fortunately we probably have 4 that are proximal that are going to be on our list to be examined, including TROP and TDXD, and for trastuzumab combination, CDRH, and B7H4.
Yeah, so the majority of the antibody drug conjugate data to date have really been in ovarian cancer, and then of course tisotumab for cervical cancer, but I think endometrial cancer is a number of really exciting targets that we will be seeing activity of these ADCs, so we're certainly very excited. Okay, well, thank you guys for that really lively discussion. We're going to turn it over to Dr. Powell, who's going to give us a masterclass on the treatment of MSI-high disease.
Yeah, masterclass in 8 minutes. There we go.
8 minutes.
Let's get
Stay on
rolling.
time, too. I am a tough moderator, y'all. I have a little buzzer that
Yeah, she mentioned
zaps
something.
them.
Yeah, cattle prod there. We all know that this big epidemic in the rise of endometrial cancer with the number of deaths going up dramatically. And in fact, more deaths, the mortality rate's going to reach that of ovarian cancer very shortly. And there's a very large discrepancy and disparity in our African-American black patients with that rise in this aggressive subtype and the resultant deaths from this. So big reason why this room is full, because we all realize this is such an important disease to be studying. And over the last century, we've made fairly little progress up until the last few years. And this is just a snapshot of how we went from prognostic markers and figuring out who should be treated and how they should be treated. We spent a decade talking about lymph nodes, and now we're really talking about how we predict better therapies, how we de-escalate therapies for our patients. Dr. Coleman will be talking about the proficient mismatch repair patients. So he's got the hard group, the traditionally immunologically non-responsive, and I get that hypermutated, ultramutated population for the defective mismatch repair group is shown on the left. This is from the TCGA, and again shows you that those patients that have a lot of mutations tend to live longer, tend to do better. We know that these different molecular subtypes also seem to have different efficacy with immune checkpoint inhibitors, to where the POLE and MSI hypermutated patients seem to have much better efficacy with checkpoint inhibition. And the other groups, also called NSMP or P53 mutated groups, that efficacy is unclear at this point. The standard of care within our NCCN guidelines do have some opportunities for checkpoint inhibition, as shown here, and in special circumstances for that pMMR population from lenvatinib pembrolizumab, as we've mentioned. We've learned a lot about in some of our clinical trials. Our POLE patients do real well. Chemotherapy seems to be important for our P53 mutated tumors for our patients. That chemo doesn't seem to do as much for our defective mismatch repair patients. And we don't, and that heterogeneity of the NSMP group is really challenging. So try to shed a little bit of light on some of this with some of our trials. Well, how do we do with single agent checkpoint inhibition? And we know not very well in the pMMR population. These are advanced measurable disease studies, and you look at quite modest response rates. Maybe a hint that the PD-1 versus PD-L1 drugs tend to work a little better, and keep that in mind as we move forward. Focusing on our biomarker positive or our defective mismatch repair MSI-high population, this is where we really see these great responses as represented in these recent cases that were shown from Keynote 158, a 48% response rate, durvalumab similar, and the Garnet study with dostarlimab also similar. Valuemab, a little bit lower response rate at 26%. One of the things we don't know from this population entirely is who are these patients? Did they have somatic, or they have a promoter methylated reason for their mismatch repair deficiency? So cross-trial comparison can be a little tricky, and we really don't know how powerful those additional qualifiers of mismatch repair deficiency are when we look at these differences. We have a lot of exciting things coming along, and GY018 and Ruby will be presented this afternoon. And I understand maybe even people might have seen some of these results. We're very excited. QOE also is adding in PARP inhibition. LEAP-001 is lenvatinib pembrolizumab versus chemotherapy in the upfront setting. So we may have a regimen, we don't even use chemotherapy for endometrial cancer. And we'll touch a little bit about dMMR in an earlier stage population. The GOG 3064 study will be quite exciting to get checkpoint inhibition for earlier group of patients. So a little bit about Ruby. This is carboplatin paclitaxel plus minus dostarlimab, with dostarlimab maintenance up to 3 years. And as mentioned, we'll get a hint of this today. We did see the press release back in December, which showed the study met its endpoints. So exciting things to be looking at with GY018. GY018 had two cohorts, the defective mismatch repair cohort that was individually powered, and then the pMMR population. There are slight differences in these studies, and I think Dr. Coleman will be talking about that in his presentation. But stay tuned to tonight, 4:55 p.m. We'll see, hopefully, some changes in the way we manage our patients with endometrial cancer with both the RUBY and the 018 study. And just real briefly, this may be a hint of what we may see, was the MITO-N3 study, was a randomized phase 2 study that was published last month in Lancet Oncology, and showed, in a smaller study here, a trend towards slight improvements with the addition of avelumab to carboplatin paclitaxel. The interesting thing, when you look at these curves, the dMMR population shown on the right showed that improved progression-free and overall survival trend. But actually, the opposite was seen in the pMMR cohort. Actually, they seemed to do a little worse when you gave checkpoint inhibitor. I don't know why that would be, but again, it's a small trial, as you see, a fairly limited number of patients. So is it because PD-L1 versus PD-1? We'll have to put this in context with the results we see this evening. And then really talking about a combinatorial approach within the defective mismatch repair population, as Shannon asked, would you use len-pem in this population? Well, let's dive into Keynote 775, which was lenvatinib pembrolizumab versus physician choice chemotherapy with either doxorubicin or paclitaxel. And this has been presented many places, but really focusing in that dMMR population, which again was a pretty small portion of the cohort, 65 patients in each arm. The patients that on lenvatinib pembrolizumab had very long median duration of response compared to those that got chemotherapy of only 4 months. The partial response rate, or the response rate was 40% in that population, so really showing quite good activity. Now you could say, well, is that better than single agent therapy? And again, it's hard to cross-trial compare when we don't know exactly what these patients all look like molecularly. This is just showing the Kaplan-Meier curve, that very impressive hazard ratio of 0.39, and again, the overall survival for that cohort hazard ratio 0.37. Lenvatinib pembrolizumab, second and third line setting versus chemotherapy, clearly the winner there. So in conclusion, importance of molecular subtypes in endometrial cancer continues to be refined. I think you saw the FIGO staging yesterday, trying to add this in. I'm sure people are writing hate letters about that already. But we have key clinical trials reporting today, and it's an exciting time to be taking care of our patients. I don't know how many patients I told over the last week. Wait till Monday. Wait till Monday. We do have robust responses, but we need to figure out what to do next after they progress on single-agent checkpoint inhibitor. Is that chemo plus checkpoint? Is that better than checkpoint alone for these patients? And then the TKI addition is all important. So thank you so much.
Great job,
Thank
Dr.
you.
Powell. And just perfectly on time.
Yeah.
People following my rules, I love it. So listen, I want to get into the first question, and I literally, as you were saying, I wrote down the FIGO staging and the incorporation of molecular. Are you all using PROMISE to guide therapy for your patients? I'll start with you, Powell.
We are, and it's not everybody. I think the 1A grade 1, 2 population that we know is low risk probably doesn't need the addition of a molecular discussion. But every one of our tumor boards where we sit and debate what we should do, we could probably inform that tumor board a little bit better with some molecular characteristics to help guide us.
Yeah, I mean, I would agree. I think that obviously it's still nuanced, right? It seems like every patient has something different, a little different that puts it into a different risk category. But we're using these things, these indicators, not as necessarily just prognostic factors, but now because we have an array of options. We're now using it in a predictive way. And so that's where our needs are, is to validate these predictive biomarkers. Fortunately, these, one of which we've already shown, but there's others that are coming, like HER2. How do we assess it? What do we use? I mean, we're putting them into risk categories, but we also need to validate them with prospective trials.
Absolutely.
Yeah, the only thing I'll add to that is, yes, I'm incorporating, a lot of us are incorporating molecular subtyping for this disease, but in addition, let's not forget the old standards, estrogen receptor positivity and progesterone receptor positivity as an addition, because in some of these low copy number tumors, they may have a strong expression, and obviously there's going to be clinical trial treatment options there and standard of care options, which we should consider.
Great. So we're going to move on to Module 2, and we will get to some audience questions in a bit. This is going to be immune therapy strategies for patients with mismatch or para-proficient disease, led by Dr. Coleman. Mm-hmm. And first, we're going to hear some cases from Dr. Tom Morrissey. The first case is a 61-year-old, 10-centimeter right ovarian mass, right pelvic adenopathy, had HIST, BSO, para-aortic lymph node dissection with a microsatellite stable carcinosarcoma, got adjuvant chemotherapy.
The next case was presented by Dr. Thomas Morrissey, a 61-year-old woman with a 10-centimeter right ovarian mass and right pelvic adenopathy. A TAH, BSO, and pelvic and para-aortic lymph node dissection was performed with gross cytoreduction and no visible residual disease. Pathology showed carcinosarcoma of the endometrium with the right ovary and right pelvic lymph nodes involved. Germline testing was unrevealing, and adjuvant paclitaxel carboplatin chemotherapy was given.
6 months after completing chemotherapy, there was a 3-centimeter nodule at the top of the midline laparotomy scar, which first we thought was a hernia, but then was a little bit more firm and was growing. We did a biopsy of that, and it was confirmed recurrent carcinosarcoma. The CT scan showed multiple intraperitoneal nodules and pelvic adenopathy, kind of diffuse disease in the abdomen. So we recommended reinstituting systemic therapy. She got 4 cycles of lenvatinib and pembrolizumab with a dramatic response. Before the 3rd cycle, the nodule at the top of the incision had completely disappeared. And the patient was feeling well, tolerating treatment well. And then after the 4th cycle, in a couple weeks, he said, listen, I have a lump under my arm. And came in, it had like a 3-centimeter lymph node in the right axilla and some smaller lymph nodes in the left. On this specimen, there was only adenocarcinoma noted. Really, the abdominal disease had responded tremendously well, dramatically well, and it appeared that there was, disease that kind of had escaped that, but really only in the axillary areas. So the question is, should we switch therapy to some other cytotoxic or other systemic treatment? Or should we just treat the symptomatic axillary nodes with another modality like targeted radiation and continue the lenvatinib and pembrolizumab, which had been controlling the intra-abdominal disease?
The key question in this case is, would you switch systemic treatment in this patient, and if so, to what? Or would you continue lenvatinib pembrolizumab and use local therapy to the axillary disease?
So I think this is a very thought-provoking question.
Yeah.
Dr. Slomovitz, do you want to tackle this? Would you keep this patient that had a perfect response everywhere else to len-pem, but just has that one axillary node growing? Would you?
Yeah, no, I think it's a great question, and it's a difficult question. In this consideration, I most likely would continue. We're seeing a good response. There's always ways to, in localized disease, always ways to use a different modality, specifically radiation, if we wanted to control that area, and then continue with the systemic therapy, because you can get the local control as well as a systemic stable.
And what about this abscopal effect? Is that real, Dr. Coleman? Will that work?
Oh my gosh. The best part I love about this case is when he asked the question, he started smiling. You could tell, he's like, no idea. So the abscopal effect, that's we've seen data on both sides of this issue. It's considered definitive that there isn't one and that there is one. So I think it very much depends on the tumor type, and I don't know if it exists or not in endometrial cancer. But I think that what Brian mentioned is probably very pertinent. And I think with that kind of level of control, I would probably PET her first to make sure there's no, do a PET scan to evaluate whether there's any other sites of disease. I probably would biopsy that also to see if there are any targets that we could go after pending the next line of therapy. And then I would probably give it a localized effect and see a stereotactic and continue treatment.
Yeah. What about you, Dr. Powell?
I would say that anybody that attended the NRG meeting over the last 4 or 5 years understands that we've been trying to come up with a trial to answer this
question. Yeah.
But these patients are so heterogeneous, it's really tricky.
Yeah.
And most people would say, it's so easy to give the SBRT in this situation. It'd be great to have higher level of evidence, but it does seem like a good option for this patient.
It feels like a natural choice. It's something focused in one spot. Everything else is under control. I mean, we see the same thing with PARP inhibitors, right? When we have somebody on a PARP inhibitor and they have one area of progression and you think, gosh, can we potentially just treat that area and move on to continue the same therapy?
Shannon, one thing I just add.
Yeah, please.
Sorry, I was raising my finger. But
I didn't see your finger. You have to wiggle it more.
No, one of the things that's interesting about this case, and we always talk about carcinosarcoma as most of the metastatic lesions are the adeno component. But he pointed out in this case that the axillary component was adeno, which made me think that maybe the ovary and the nodes were actually the mixed tumor.
Yeah.
And so maybe this is an indication where a second biopsy may return a different type of result.
Great. Okay, so now we're going to hear a case presentation by Dr. Dana Chase from Phoenix, Arizona.
The next case is presented by Dr. Dana Chase, the 68-year-old woman originally diagnosed with stage 1B, grade 1 endometrial cancer.
Had hysterectomy and sentinel lymph node dissection. No adjuvant therapy was given. Now she has a vaginal recurrence and lymphadenopathy, MMR intact. Do you treat post-op patients based on the PORTEC NCCN guidelines, or do you use the GOG traditional risk factor? And you could also ask if you would treat with radiation at this point, since she hasn't gotten radiation either.
Dr. Chase wants to know how you would approach the use of adjuvant radiation therapy or chemotherapy in this case when the patient presented, and whether you would use the PORTEC NCCN guidelines or the GOG risk status in making this decision, and also how you would manage the patient at this point.
So what do you think, Dr. Powell? You're the radiation expert. How do you determine, so this patient had a 1B endometrioid type and did not receive adjuvant therapy. Would you have done something different, and how do you decide?
Well, if I gave you the answer, we wouldn't have all the debates in our tumor board. No, it's personalized and it's changed, and as we add in molecular characteristics, we'll know more. We will have a de-escalation study about to open, so if the patient's POLE or NSMP ER positive with P53 wild type, we're going to de-escalate those patients to really give them just close observation, because we think those patients are the least likely to need radiation. Beyond that, vaginal brachytherapy we use fairly liberally, mostly because it has very little side effects. Beyond that, so if they're stage 3 or 4, we know from our presentation yesterday from GOG 258, radiation's not helping those patients. Their quality of life is worse and their survival is slightly worse, not statistically, but the trend is worse. So I think planned pelvic radiation for advanced stage endometrial cancer is done.
Yeah, I think this is a good case for, we talked about it in the last case about how the annotation of these samples is now increasingly becoming part of our decision-making triage at the very, very beginning.
Yeah.
And I think we use both. I think we try to come up with a totality of risk assessment, and to make decisions. And certainly the high-grade lesions that have, like for instance, a HER2 amplification, that has impacting our approach to a patient like this, as well as histology. Mm-hmm.
Yeah. So what about the second question, Dr. Slomovitz? So this patient has pelvic nodes and a vaginal recurrence. Would you consider what Dr. Chase mentioned? Do we use radiation there, or are we looking for something systemic at this point?
Yeah, in the same light as what I was saying, just not to be too repetitive, but in this setting, in the absence of other disease outside of the pelvis, I do think that we can get whole pelvic radiotherapy and vaginal brachytherapy in combination to help control this patient.
Yeah, I think we like a local approach if we can, but certainly the systemic options are increasing, as you heard, with the different trials that we're seeing.
And again, just one point.
Please.
Without cisplatin.
I was just going to say.
GOG 238,
Yes.
many of you may not have seen it because it's not in manuscript form yet, but cisplatin did not help that situation.
That's right.
Actually looked a little worse.
Right.
That's a great point.
Which was very surprising.
Mm-hmm.
And we had a question from the audience that I want to tackle right now, since we have a moment. We're seeing this increasing incidence in endometrial cancer, even type 1, type 2, those old versions. This is the question. Why are we seeing rising incidence of endometrial cancer across all histology types, all molecular types? You want to start?
Yeah, no, it's there's a lot of reasons. Obviously, inherently, the rate of obesity continues to rise in this country. which is something that hopefully we could, it could be better controlled, but we're seeing that. In addition, we are focusing a little bit more in our diverse populations, and we know that Black women have twice as much risk of dying from endometrial cancer than white women. You know, that's not necessarily directly answering the question, but I think in following different subgroups closely, maybe not as closely as we did previously, as they deserve to, I think we're going to be identifying more and more cases and getting the full picture. And that full picture, in fact, may be showing the increased risk of endometrial cancer.
Mm-hmm. Yeah, I think there's some truth to that. You can imagine when you're looking at mortality statistics, many times the annotation of the primary is unknown. And I think what we're doing a better job of is, as we get more information, is we're actually migrating those into categories that were unknown before into categories of disease. I think that is contributing to some of this. But you would expect that to be across multiple sites.
Right.
So maybe, as Brian mentioned, maybe we're starting to annotate certain populations better than others.
But I mean, we know endometrial cancer is one of the only solid tumors with a rising incidence. Mm-hmm. Everywhere else, we're seeing at least stabilization or even reduction. Yeah, go ahead.
And just the one statement to add to that, the number of deaths from endometrial cancer is in fact going to outpace the number of deaths from ovarian cancer.
Right.
That's right.
Hand in hand with that, it's great that our clinical trial portfolio is increasing because that disease deserves it.
Well, and we've seen this, and this got presented even yesterday in the plenary session, that the amount of money, the amount of funding that's being given for gynecologic cancers overall, but especially endometrial cancer, is low as opposed to the incidence and the impact of the disease. So there's a lot of areas where we have opportunity to improve. Mm-hmm. Well, okay, thank you all for that great discussion. I think we're going to head into our next lecture. Dr. Coleman is going to take us through mismatch repair proficient disease.
Great. Thank you so much, Shannon. So I'm going to start this discussion where Matt also left off, and I think it makes sense because a lot of the trials that we're doing now are looking at whole populations and then segregating them on this basis of the biomarker. So I'm going to focus on that, the kind of the opposite of what Matt shared with you. So I'll be covering the copy number low and the copy number high that don't have evidence of MSI. But I also want to draw attention to the POL E, because this may come out to as important because of the differential efficacy we might be able to see or overall survival we might see in this subpopulation. You'll notice if you go down where the MSI MLH1 category boxes, they're not all of our POL E's, although they may have high TMB, are not MSI. Okay, so this is another cohort of patients. It's a small cohort, but it's one that we need to pay attention to as we look at the MMR-P population. So as Matt mentioned during his presentation, I'm going to take these same studies and actually carve out the MMR-P populations. And you can see here, for both Garnet and Phaedra, the response rate for these single agents is about what we expect for chemotherapy in the same kind of setting. So very relatively single digit or low double-digit response rates. The largest of these trials is the Garnet trial, which has two cohorts. And we talk a lot about the DMMR population, which led to its approval that Matt mentioned. But we also have this group A2, which is 161 patients. So it's a very large sample size for us to draw some inference from. And if you can see, this was presented at ASCO last year by Anna Oknen. And you can see there's about a 15% response rate in a much more characterized patient population. The vast majority of these patients demonstrating partial responses if they had a response. And you can see about 35 to 40% of the population actually probably got some benefit from the therapy without evidence of progression at the first assessment. That's everything kind of on the right-hand side of that curve. Very characteristic in this setting with many agents, not just immunotherapy, is the L-shaped curve. I like to use this as a nice education for lots of different ways of talking about how you interpret a Kaplan-Meier curve. But with respect to this, you can see that there is definitely two populations here. We have a population that's obviously not responding at all. Mm-hmm. And you can see with that 50% or maybe 60% drop-off by the first assessment. And what's really characteristic in this population is that it's not necessarily just a stair step. That kind of event happens when there's no progressions due to in between an imaging cycle. So in other words, clinical deterioration. Here, you see a slope. It's a rapid cliff. So patients are progressing while they're on the treatment before they even get to the first assessment cycle. But then you've got that tail, which is about 10 to 15% of patients that did phenomenal out to over 4 years, which is something we wouldn't expect in this recurrent population. So in this setting, we've learned a lot about the tumor microenvironment. We continue to learn more, and we're so thankful to everybody who works in this space. We've studied each of these agents as single agents. So we talked about the immune checkpoint inhibitors as a single agent. Lenvatinib has also been studied as a single agent in a number of different settings. The largest study was done by our good friend Ignace Vergoda, who looked at lenvatinib as a single agent in endometrial cancer patients and showed about the same response rate, about 15-16%. But there's a lot of reasons to use these drugs together. And I've just listed here that the different signaling pathways do have impact in the tumor microenvironment, which may amp up the potential for an immune response. And I just listed here where those factors could be, especially on its impact on VEGF. So that then led to the hypothesis for this trial. This was Keynote 146, led by Vicky Mackyer. And this was looking at, in a phase 2 setting, a single-arm, open-label study that was published in Lancet Oncology in 2019. And we've used this slide over and over again because it highlights a number of really important characteristics. One is that that a lot of the efficacy was seen in the microsatellite stable population. And two, PD-L1 status really doesn't help. So, and this has been characterized over and over again with the lack of correlation between PD-L1 status, TMB, and MSI. But that was a big response rate. This was updated in 2023, just about a month and a half ago. Looking at this same data set, you can see the response rate now at 38%, with about 9% complete responders and the clinical benefit rate of over 50%. This is really quite impressive because the duration of response in these patients that had responded was 23 months at the median, which is very much different than that L-shaped curve I shared with you before. So that was hypothesis generating. Right? Although it led to an accelerated approval and we had access to it, the proper approach to this would be to then do a phase 3 study to compare it against the standard of care, which was done. This is Keynote 775 that Matt presented. A very large study that looked at the two cohorts. What we saw in this patient population was an impressive, really impressive, and really nicely done statistical model where they had addressed each of these particular endpoints that had to be addressed in a analytical fashion before moving on to the next step. But I'm going to present them in a little different order. So the first thing, because this is clinically relevant to us, is the probability for an objective response. Because if you think about the patient you treat, you're going to institute therapy, and then you're going to be reevaluating for response, right? We're looking for progression. We're looking for non-progression to continue going. And you can see what the objective response here is basically double, and the duration of response also more than double. So the way the analytical was done in this patient population was to look at this all-comer population, look at the dMMR population, then pass it to the all-comer population. But in this population, we also had a non-analytical endpoint of the pMMR population. You can see what that curve looks like. There's separation all the way through the tail. And of course, this was confirmed in the all-comer. And then obviously in the overall survival, even more impressive, again, seeing separation all the way through the tails of the curve in both the pMMR and in the all-comer. And so this complemented what Matt just shared with you, showing the efficacy in the dMMR population. Now, interestingly, we also saw this in the pMMR population across all of the histologies. So this, again, another hypothesis-generating statement, but you can see in endometrioid, serous, and clear cell that we all see white between those two curves, suggesting that there is a broad and robust effect of this combination in the pMMR population, but not without a cost. So we know in the quality of life assessment, this was done at week 12. You can see that, that both of these regimens caused overall mostly a deterioration in the important factors that we see with patients, and that it comes from the issues that we have to deal with in terms of adverse events. Now, because this has demonstrated so much activity in the recurrent setting, the idea would then to go and see if we could replace our best standard of care. And so this is LEAP-001, which Matt just recently presented here in the last talk, and you can see how this design was set up. Another large trial, 720 patients, looking at these endpoints of PFS and overall survival. Now, both Ruby and GY018, as you'll hear about later, actually it's probably ongoing right now in the virtual ESMO plenary, that will have data on the dMMR populations and the pMMR populations. So Ruby Part 1 has both of those populations on that will be reported today, as well as the GY018. Now, as Matt mentioned, the pMMR population is analytical in this study. And so it was appropriately powered to address that question. But both of these are looking at the role of chemotherapy plus or minus immune checkpoint inhibitor followed by immune checkpoint inhibitor maintenance. Now here's some key, this is a slide I made just to kind of highlight the differences, and you'll hear some of this in the discussion today as well this afternoon. But you can see that there are some notable differences here, and I really want to highlight this because these differences are material to how you assess the two trials independently. And I'm not going to give the punchline away, but I do want you to know that and spend some time looking through these, and then in your own mind, think about how this may materially impact the outcomes. I think it's important. You can see there's differences in the duration of treatment, there's differences in patient populations, the performance status, when they could start and come on to study, what was the histology, and how the outcomes were actually assessed. But nevertheless, these were wins. And so, as Matt mentioned, it's a great time to have something like this. We haven't seen anything like this in endometrial cancer really ever. So we're very excited to see this change our lives of our patients. So just some take-home points. The majority of our patients are stable, and so that's why it's important to address these issues and how we can improve the lives. Molecular characterization, as we've already addressed today, is absolutely critical to understand the best options for our patients. The checkpoint inhibitors by single agents have been relatively disappointing, except in the POLE cases. But now with this combination of lenvatinib and pembrolizumab, we have seen level and evidence of efficacy in a very nicely done study, and we hope this will continue to redefine the frontline space. We anticipate the results of the ongoing trials, including DUO-E, which is looking at the addition of a PARP inhibitor into this space, and to have more discussion in the future and just an event like this to figure out how the heck we're going to tear all the data apart. So thank you again.
Yeah, thank you, Rob. Very well done. Yeah, sequencing is going to be the issue, and we perhaps will get to that a little bit later. So let's transition to Module 3, which is going to be exploring the diagnosis and management of adverse events that are associated with these checkpoint inhibitors, both alone and in combination therapy. And we're going to start with a case. This is Dr. Morrissey again, presenting his patient.
The next case is presented by Dr. Morrissey.
62-year-old woman with a history of a BRCA mutation. She had a mother and sister with premenopausal breast cancer, and that's what led to the genetic testing. She underwent risk-reducing bilateral salpingo-oophorectomy at age 42. So just the tubes and ovaries were removed, not a hysterectomy. 12 years later, she developed postmenopausal bleeding, went to her gynecologist, and off his endometrial biopsy showed serous carcinoma. So the question at this point, in terms of with a BRCA positive patient with high-grade endometrial cancer, would there be a role for treating with a PARP inhibitor in this patient for her endometrial cancer? And then the other thing that was brought up, in terms of if a hysterectomy had been done at the time of the risk-reducing salpingo-oophorectomy, that we may have avoided this situation. I've also had a couple other patients that had or patients we've only done the salpingo-oophorectomy and who've ended up with not serous endometrial cancers, but more of the routine type grade 1, grade 2 endometrial cancers at a later time, which again may or may not be related to their mutation at all.
Dr. Morrissey brings up a number of questions, including the role, if any, of PARP inhibitors in patients with endometrial cancer, and the role of hysterectomy, if any, in risk-reducing surgery for patients with BRCA germline mutations.
So intriguing questions. I'm going to start with the second one because I think prevention before treatment, right? Dr. Slomovitz, what do you do with your risk-reducing surgeries?
This is an excellent question. Maybe I missed it. Was she BRCA 1 or 2?
I don't know that he said.
So basically, the data is not that robust, but there is some data that would suggest that patients with BRCA1 mutations do have a risk of developing a serous carcinoma of the uterus. So in my BRCA1 population, actually in those patients, I would offer a hysterectomy with the salpingo-oophorectomy as one of the options. And I sort of do it based on very scant data, but it is there. And as we know, uterine serous carcinomas does portend a worse prognosis. In my BRCA2 patient population, I go by other uterine risk factors. If there's enlarged fibroids, if there's any symptoms, in those patients that may want to have a smaller dose of hormonal replacement therapy. Obviously, it's a little simpler without the progestins, but that's how my current management is. And truthfully, some patients say, I want everything out. While on the flip side, some patients say, if I don't need to take it out, don't take it out.
Yeah.
Yeah.
It does make you wonder, though, if we should just be just saying, you got to have everything out. Dr. Powell, do you do anything different than what Dr. Slomovitz?
No, it's definitely shared decision. And, I think we get jaded by Dr. Morrissey's case. You know, it sticks in our mind like, darn, we kind of messed up here.
Yeah.
But, when you look at population-based medicine, we do have, it is a hint that the BRCA ones certainly are at risk for this. Was all the tube removed? Did they do everything right? Who knows? But, with minimally invasive hysterectomy now, the patients are fairly accepting of adding that in.
So she was BRCA too. So to your point, you might not have
Right.
necessarily considered it. But what about treatment? I'll start because obviously PARP inhibitors and endometrial cancer are a long-term love of mine. I think, on standard of care, it's going to be a little bit tricky, right? Because it's not labeled in the space. We are moving more towards directing that targeted therapy based on aberrations in the tumor or based on hereditary aberrations. So it makes sense. And those of you that attended my presentation yesterday of the combination of PARP and MEK, 2 of the patients that had benefit from that regimen had BRCA2 mutations. And so it's very intriguing, certainly, to think about using a target against that. What do you think, Dr. Coleman?
Yeah, I think you're right. I think as we learn more about replicative stress conditions and how we can identify it, I think this is where it's going to be really exciting. Because there are other factors here that obviously we would want to know.
Right.
Obviously, for a still clinical research arena. But replicative stress, and we just heard earlier this morning, for instance, for WEE1 inhibition, for ATR, AT1, CHEK1, 2, and then ultimately PARP inhibitors. Fortunately, in DUO-E, and Ruby Part 2, we'll have some evidence on how that plays with respect to the frontline approach. But again, this is another space where we really need biopsy. We need to annotate these specimens and move from there.
Well,
Again, looking for HER2 in this population.
Absolutely.
Yes.
Don't forget,
Absolutely.
this could be HER2 positive, and she might be eligible for GY026, looking at the addition of anti-HER2 therapy.
Yeah.
we often get asked too, just as a note, about homologous recombination deficiency testing in endometrial cancer. We don't have a lot of data. There are some small papers that have looked at this, but the cutoff is really unclear. So hopefully some of these larger studies will help inform that as well for benefit. Okay, we're going to move on.
Just one quick point there, and I know GY026 was mentioned. If you don't have that protocol open, as you may or may not know, the addition of Herceptin to the regimen is on the NCCN guidelines. So you can, in fact, offer this patient who's HER2 positive with carboplatin and paclitaxel, Herceptin, based on the NCCN guidelines.
Great. So we're going to take a case from Dr. Chase.
The next case is presented by Dr. Chase, a 76-year-old woman with stage 1B serous endometrial cancer, which was MMR intact. The patient was treated with hysterectomy, lymphadenectomy, omentectomy, and then 6 cycles of carboplatin paclitaxel. 11 months later, she was found to have metastatic disease to the lungs and was started on lenvatinib pembrolizumab.
At cycle 3 of pembro, she was noted to have diarrhea, and we told her to hold the lenvatinib. Her diarrhea improved, and then at cycle 4 of pembro, she was given pembro again, and then a couple days later was admitted for greater than 8 episodes of diarrhea a day. A diagnosis of colitis was made. GI was consulted. She was given high-dose steroids and infliximab. She was in the hospital for 2 weeks with acute renal failure to thrive, ultimately was discharged to SNF or rehab. Interestingly enough, her CAT scan showed complete response. So one question is the triage of diarrhea on the len-pem regimen. So what does the expert suggest? Definitely, in my experience, it's more common to have diarrhea from lenvatinib than pembrolizumab. So that's why I stopped the lenvatinib first. She did improve with the steroids and the infliximab. So would you retreat with IO in this patient? Would you switch to a different IO regimen? Would you just not do anything since she's in remission at this point?
Dr. Chase raises the issue of management of diarrhea in patients who are receiving lenvatinib pembrolizumab and determining whether it's due to the lenvatinib or the pembrolizumab. A second important question is for patients who do experience autoimmune colitis while on a checkpoint inhibitor, would you consider re-challenge once symptoms have been resolved? Or, in Dr. Chase's patient, would you consider just observation at this point without specific therapy?
So very intriguing questions. I think that, to hit one of our first points, I think this is what most of us would do, right? Especially given the timeline of a few cycles in, seeing diarrhea. It's easy to stop the TKI, and I'm going to talk about this in a couple minutes, but stop that TKI and see if the diarrhea gets better. But then, for the example of this patient, clearly, once you restart it again, she developed the colitis. How do you tackle diarrhea and assessment of that, Dr. Powell?
Again, raising a great point. We think in general, if it happens early, first couple cycles, probably more likely the TKI. If it happens later, raise up your radar that this could be immune colitis. But always have immune colitis on your mind, because that's the one where they're really going to get sick and could end up with a long, prolonged recovery like this patient. So low threshold to evaluate this patient for immune colitis. Re-challenging this patient in a CR, probably not. I would probably be pretty hesitant, but I would be following that patient pretty closely. I would re-challenge if they relapse, perhaps, and they're doing well, but with a lot of caution.
Yeah.
I mean,
that's why I went.
The problem is we don't have a lot of options for this patient.
Right, you're right.
Outside of that work.
Yeah.
Go ahead.
I wanted to echo that point that, also evaluating the patient to make sure there's not another underlying immune source for this. So inflammatory bowel disease or another opportunity for a colitis that would put them at risk. I would follow them pretty carefully too, because it does make me very nervous. And, I think all of us have had one of these kind of patients that were in the hospital for, more than 2 weeks and near-death event. So I would be very, cautious.
Dr. Slomovitz?
A little bit tangential specifically to the case, but remember, this was after adjuvant therapy, 11-month interval. So actually, this patient would have been eligible, because we're talking about limited treatment options.
Yeah.
This patient would have been eligible for Ruby, 3031, would have been ineligible for 3041, because in endometrial cancer, as you know, we don't have a definition of platinum sensitivity or platinum resistance, but carboplatin, paclitaxel, a lot of times we're scared away from it, but actually that's another treatment option. Again, tangential to the
Excellent.
subject.
No, it's an excellent point.
And what about, so to go back to the way you're managing the therapy, so what if you stop your TKI and the diarrhea doesn't, it starts to get better? What else do you use? Do you use anti-motility agents? Do you support that patient? Like, how do you get that patient back on a TKI if you've identified that that's why you have diarrhea? Or she has diarrhea. Hopefully you don't have diarrhea.
Yeah. No, he probably does.
Dr. Powell? Do you want to tackle that, Dr. Powell?
Is that directed to me?
Giggle.
Oh, I just had some cramping. I don't know. Yes, I would use anti-motility agents. And I imagine you'll be going into that in your talk, but definitely. But again, careful precautions. Patient education is so critical with using this combination and having them make sure they have phone numbers to call to react to these problems quickly.
Go ahead.
As I say, if this is not a prolonged, a little not as quickly as I would expect from that, I'll sometimes scope these people too.
Yeah. Yes. Again, early and often getting that multidisciplinary team involved is critical to really help your patient have the best options. So let's get into that. We'll go into a little bit more detail. So I'm going to talk a bit about just the diagnosis and management of adverse events with these checkpoint inhibitors. So first, what's the rationale? Why do we think these immune-related adverse events occur? Well, the bottom line is there's a lot of hand-waving. We don't really know, but there's lots of potential things that could be causing it, right? There's T-cell responses, there's antibody responses, there's cytokine responses, all of which could be potentially causing different things. Like, for example, we see the increasing level of inflammatory cytokines that seems to be involved in the development of colitis. So there's a number of reasons why these things might be happening, but the bottom line is we have to be prepared. And because we're creating this inflammatory environment, we're creating an inflammatory response, that inflammation can go everywhere, right? We're taking the brakes off the immune system, and we're allowing the immune system to recognize abnormal, but unfortunately sometimes it also recognizes normal. And so we can see inflammation really across any organ system in the body. Certainly there are more common ones, things like Thyroiditis we see quite commonly, pneumonitis, colitis. These are the things that you're seeing in your clinic, but we can see it anywhere. We can see carditis, we can see bone marrow issues. And so it's important to make sure you counsel your patients to really report anything. No symptom is too small because you want to act quickly and allow the patient to stay on this potentially life-prolonging therapy. So there are some things we can consider around prevention of these treatment-related adverse events, and that includes selecting the right patient. You know, we've heard from our two first speakers that the lenvatinib and pembrolizumab regimen can be quite difficult, so making sure you're getting your patient kind of the best possible place that she can be before you start is really essential. Really considering your clinical trial access. These patients that are on clinical trials get monitored very frequently. They get their home phone of their nurse or coordinator, and it can be very helpful to help manage those adverse events. And then, of course, I think I've said this a couple times. I'm going to say it a couple more times. You cannot overemphasize multidisciplinary care. We have experts in the community. We have experts in our centers that we can lean on to make sure we're managing these patients appropriately. Now, there's some general principles across really any immunotherapy and any abnormality that can occur, any adverse event can occur. The key tenets, there's three. One is you got to educate the patients ahead of time, especially these patients that are coming off things like chemotherapy. This is a very different array of adverse events, and you want to make sure your patient is aware. If she has outside providers, keep them in the loop, and then you want to keep a close eye. We're going to be assessing pretty much for any of these adverse events every cycle, at least for the first 3 months, although I think most of us will keep checking them because you can see development of these adverse events really across the treatment continuum, and then just maintain a low threshold for intervening and trying to reverse that inflammatory situation. In general, grade 1 is going to be symptomatic management, and you can continue the IO. Grade 2, you want to stop your IO, let the patient recover, and again, use that symptomatic management. And generally, we're going to be looking at something like an oral steroid here. And then, of course, for grade 3 or 4, discontinue, get them back to where they need to be, get them back to a grade 1 or lower, and consider whatever agents are necessary. IV steroids, drugs like infliximab, vedolizumab can be very helpful. And then, of course, if you do transition to steroids, make sure you're managing those side effects as well. We know we can see with glucocorticoid use hyperglycemia, gastritis, edema, other issues. And so trying to get out in front of those things and make sure you can protect your patient is important. And that includes trying to prevent opportunistic infections. We can see pneumocystic carini, pneumocystic urovenji, I don't know if I said that right, but those patients need prophylaxis with sulfamethoxanol, trimethoprim, dapsone, and others. So just kind of reviewing what we've already seen, but focusing on the adverse events for the Keynote 775 treatment, when we saw the combination of lenvatinib and pembrolizumab, we saw some very specific abnormalities like hypertension, hypothyroid, diarrhea. These are the things that you're going to have to manage day to day in your clinic. I love this chart. If you have not read this paper, this is required reading. This has a really nice guide of all of the most common adverse events with the lenvatinib and pembrolizumab combination and when to expect them. And it just really helps, again, counsel your patients and also helps you potentially to tease out what might be causing your abnormalities. So here are some of the guidelines around toxicity management, specifically for lenvatinib and pembrolizumab. What we do is we really try to get out in front. So we send patients home with a blood pressure cuff. We want them to be monitoring for that hypertension. We'll even send them home with antihypertensive prescriptions. We tell them not to take them without calling us, but that way they already have something at home. So if they start to spike up and develop that elevated blood pressure, you have a leg to stand on. In addition, diarrhea, the big thing here is making sure they're reporting. You need to know what their baseline is, because many of these women with endometrial cancer will have baseline increased bowel movements. So it's a change from baseline is how you're going to grade this toxicity. And then again, sending them home with anti-motility agents that they can have at the ready is very reasonable. Interrupting that dose of lenvatinib to try to tease out the timing, to tease out the cause of the diarrhea is also very helpful. As Rob said, when we're looking at things like fatigue, you want to rule out other causes, right? Exercise, it's the exact opposite of what we feel like doing, but it is absolutely the best way to prevent and treat fatigue. And then, of course, similarly with nausea, having them take home antiemetics, consideration of giving those antiemetics in a prophylactic fashion can be quite helpful, in addition to the usual things we do to manage nausea: small, frequent meals, high-fat foods. So, this gets at the idea of that overlap, right? So we know there's two different mechanisms of action for these two agents, and they're going to cause adverse events that may be similar, but the cause is different. You can see on the left the traditional things that are associated with just immunotherapy, like pruritus, pneumonitis. Those are easy to tease out what is causing the problem. On the right, things like hypertension, stomatitis, generally more associated with that tyrosine kinase inhibitor therapy. It's when we've got that overlap in the middle, the rash, diarrhea, fatigue, hypothyroid, acute altered mental status, that's when we really need to start utilizing the tools that we have to understand. Sometimes we can look at the timing, right? We know that early on is more rare to see immune-related adverse events. It's going to be a little bit later in the course, so leaning on that TKI there. But then things like nephritis and endocrinopathies, those can happen at any time in the treatment continuum, even after discontinuation. So bottom line, I think practical management: hold your TKI because it has that shorter half-life. Assess whether or not you see something get better. Use liberal supportive care. And then if those symptoms resolve in a few days, your TKO is likely the cause. If they don't, then you're moving forward with steroids and other support as indicated. As far as combinations, we don't know what the adverse event profile is going to look like when we talk about these trials that both Dr. Coleman and Dr. Powell presented, but the anticipation is we're going to see those IO-directed or those IO-related adverse events, to be determined if it's any more than what's been reported in other solid tumor types. We'll see in about 3 to 4 hours. And so please, I think we've all had this slide, watch the presentations. They seem to be positive, but how positive? Can't wait to see. So bottom line, early recognition, early education, clarify your cause, and then don't be afraid to bring that patient in if you think you need aggressive therapy, and consult. Get your team around you. So with that, I think we have, let's see, just a minute for questions. I just have a question, and I don't know if you all have seen this as well. This case that we saw, that bonkers adverse event in the setting of a complete response. It's basically, do you think there's a correlation there to the amount of toxicity we see and the amount of anti-tumor activity that we see? What do you think?
Gosh, I always hate to say that there is a relationship, because then all people start then trying to get to toxicity. Yeah, I think it's a reflection of just of the efficacy or the impact in the tumor microenvironment that are more flexible. I don't think we've been able to actually document accurately that there's a relationship in all tumor types. And like I said, I get leery about making that correlation, but it could be, some reflection that there is a robust immune response, and we're seeing the autoimmune components of that. Mm-hmm.
Go ahead.
I think this is, sort of related to this, but again, indirectly. The starting dose of lenvatinib is 20, according to the label. And I know if I asked everyone in the room to raise your hand and said, who started at 20, there'll be very few hands, and everyone has a different dose. The dose reduction guidelines are good. My fear of starting at a lower dose that's very tolerable is that might not be the therapeutic dose. Because, in fact, in this point, the toxicities may be in some way related to response. So what I encourage you, I've started less than 20, and a lot of us have, but what I've encouraged you, if you're going to start less than 20, have a good reason to, either comorbidities or frail, but if you don't have a good reason to, start at 20 with liberally reducing doses based on the label's recommendation.
Great. So we're going to transition to our last module, which is novel investigational agents and strategies under evaluation with Dr. Slomovitz. But first, Dr. Lyndsay Willmott is back with another case. She's got some good ones, so.
The next case is presented by Dr. Willmott, a 71-year-old woman whose status post-TAH, BSO, and lymph node resection for a serous carcinoma of the uterus.
She did have preoperative CT scan, which showed some enlarged pelvic and para-aortic lymph nodes, but she was thought to be a good candidate for surgery. Unfortunately, when she underwent her surgery, some of these para-aortic lymph nodes were just really extremely fixed and unresectable without potentially doing vascular reconstruction. So there was residual disease at the completion of her surgery. So she was started on chemotherapy and had testing of her tumor to look for HER2 positivity, which revealed 3+ staining. So based on that, she was started on trastuzumab along with her cytotoxic chemotherapy.
Any questions?
You know, obviously in the breast cancer world, there has been some pretty tremendous data looking at antibody drug conjugates directed against HER2. And I think that there could be, you know, phenomenal role for those medications in the uterine cancer patients who are HER2 positive or in other gynecologic malignancies that are HER2 positive. So I'm curious, would you consider for this patient, if she had progression while on her trastuzumab, would you consider transitioning her on to one of these ADCs directed against HER2? They're being able to expand it into patients who perhaps have lower grades of HER2 staining, allowing it to be accessible to more of the population.
Dr. Willmott's case raises the issue of who and when and how to test for HER2 overexpression in patients with endometrial cancer, and also the future of newer anti-HER2 therapies, including antibody-drug conjugates such as trastuzumab deruxtecan, currently being utilized in breast cancer, and whether this strategy, as in breast cancer, can be used in so-called HER2-low disease.
So we kind of started hinting at this. I think this is a HER2 fan club up here.
Yeah, right.
Dr. Coleman, what do you think?
I really love the question about asking about how you assess for HER2 overexpression. I think most of us would be comfortable sending a patient that we know has uterine serous cancer for HER2 evaluation. The question is, what's positive, right? So, and how do you assess for positivity? So in the past, you know, we know that, for instance, HER2 in gastric cancer is assessed differently than it is in breast cancer. And this is largely due to the way that the staining happens on the cells itself, so the heterogeneity within the tumor and also the surface staining. So there's different criteria that are used. In general, we try to follow the breast guidelines for endometrial cancer, but there are some variants about what those staining patterns can be. And so I think that's it's good to know. And because, as Neil mentioned in his discussion about the HER2 low, as we see some of these, the efficacy that we've seen in some of the preliminary phase 2 data or in the basket trials that are looking at these ADCs that are using the ERB2 as the antibody drug conjugate target, we're seeing activity in lower expressing tumors. So again, getting the full report of what's going on in the tumor with respect to ERB2 expression as well as the amplification is going to be, I think, integral to understanding what kind of therapies we can go forward with. In patients who have progressed on a trastuzumab, I don't think we know for sure, obviously certainly not in endometrial cancer. There are some data in colon cancer about adding a second targeted TKI in that space. That we have seen some responses to. We don't really know necessarily that if there is still expression of the ERB2 on the tumor, even after trastuzumab as a focus target, that the ADCs would actually work. They may work. But we would also want to test for other expressing components like TROP and others that may lead to obviously those types of therapies.
Dr. Slomovitz?
Yeah, no, I think, Rob, that's a great comprehensive answer. One thing that I just want to highlight is which patients with endometrial cancer you tested. And I just want to review that. Obviously, the serous patients, the NCCN recommendation is based on that. But truthfully, we should be looking at it in the carcinosarcomas. And I also look at it in the grade 1, the high-grade endometrioid tumors, because these are the groups of patients that are more likely to overexpress or amplify the HER2. And I think there's an opportunity, barring from the serous patients, there's an opportunity to increase the use of Herceptin, trastuzumab, in that population of patients, which I think is extremely important. And I do also think that it's important to evaluate this marker in the earlier stage patients as well.
Perfect. Just to follow up on what Brian's comment about early stage, Britt Erickson had a really nice review looking at HER2 in stage 1 serous cases. HER2 positive, 50% recurrence rate. HER2 negative or low was 19 or 14% response rate. And that's despite most of those patients getting carboplatin paclitaxel chemotherapy. So not only prognostic, but hopefully in the future predictive of who's going to benefit from further therapy.
Great. So now we're going to take the last case from Dr. John Chan in San Francisco.
The next case is presented by Dr. John Chan, an 82-year-old woman with metastatic recurrent disease following surgery for stage 1B, grade 2, MSI-high uterine cancer. Following treatment, then progression on chemotherapy, she received immunotherapy, but again had disease progression. Both Dr. Chan and the patient were very interested in a clinical trial.
Based on the patient's MSI-high tumor, it seems that this patient should have responded to pembrolizumab. Would the experts try a second immunotherapy, maybe a different immunotherapy of this class, like dostarlimab? The second question I would have is, would the clinical experts want to use a combination of adding an antivascular drug? And is lenvatinib a good antivascular drug? And would the clinical experts use this combination in this space? We subsequently evaluated her tumor and looked for biomarkers that could make her eligible for novel therapies under the TAPER trial. We found that she was able to get talazoparib orally in the TAPER study.
Dr. Chan's case not only raises the issue we discussed previously of management of patients with MSI-high disease with progression on immunotherapy, but perhaps another more important message and question from this case is, what are the compelling ongoing clinical trials available to patients where no approved therapies exist, and in particular, adaptive biologically based initiatives like the TAPER trial, and what can be done to improve access to these valuable studies?
So I think, we certainly have, this has come up a couple of times already about, what do you do when someone doesn't respond? So I think the audience knows kind of where we would go with that. But I want to ask a different question. Dr. Powell, why isn't this patient having a response to therapy? How are we failing this patient with an MSI-high tumor?
Yeah, again, I think, looking at the specific reason for the microsatellite instability may be important. So promoter methylation may have less response. I think Alessandro Santin's recent publication looking at this really detailed look at the immune pathways and how there's some differences seen. We're just learning about this. We don't know the complete answer. And should, as Dr. Chen said, should these patients be getting an antivascular therapy with their checkpoint inhibition, or should we be adding chemo to that? We just don't know yet. And there's a lot of great questions. Checkpoint after checkpoint, even in melanoma, where it's most studied, is still quite controversial. So I don't know that I'm quite ready yet, but we will see some checkpoint after checkpoint in GY025. Right. So if you were on 018 or Ruby and you progress and you're mismatch repair deficient, you can go on that, which would be ipi-nivo versus nivolumab alone.
And then I think, I want to go to both of you. I think there's really a very interesting cadre of trials now that are using biomarker expression to direct therapy. Things like the TAPER trial, which is more like a community-based trial, but also combo match and others. Brian, any thoughts about that, about what direction we should be going in there?
Yeah, no, that's a great point. I think these biomarker-driven trials, which will assign patients an arm based on the molecular profile, and even an arm if there's no biomarker negative profile, is our future. Individualized care is something we've been talking about. How individualized it has been, I'm not sure, but we can do better, and I'll talk about it a little bit later as well.
Yeah, Rob, do you?
Yeah, I was going to say, I think we're going to hear about in the next presentation, but I think the question he asked about how do we increase access to clinical trials, one of them is what you just mentioned, how can we make the eligibility criteria more flexible? And there was, you heard yesterday or 2 days ago, Carol Agajanian talking about the opportunities that we can do to make these trials more accessible to our patients. I think that's really the way forward for this. Mm-hmm.
Well, and I think, we not only the eligibility, but the language that we use around the eligibility is so critical as we're developing these study populations. We get more and more restrictive, and then the results become completely ungeneralizable, and we can't get those drugs to patients. So making sure that we have adequate representation is so critical. And what I loved about Dr. Agajanian's talk, we had just spoken about this at the SGO Bridges course as well, is we are victims of cut and paste. Yes. Everybody wants to do things quickly and easily. And so we're like, okay, this is the eligibility from this trial. I'm just going to move them on over. And by doing that, we are limiting the options for the patients.
Agreed.
The other thing I was tickled about was that another patient with endometrial cancer getting a PARP inhibitor. It's like Dr. Love made this for, it's like Shannon's my moderator. How can I make her happy? I'm going to give her lots of patients with PARP inhibitors.
Yep.
Yeah, please go ahead.
Just one quick point, because they're talking about antivascular therapies. GOG 86P was a 3-arm trial in the frontline setting, carboplatin and paclitaxel, with different additions. In one arm, they added bevacizumab. Now, the trial itself did not support going further, but when recently there was published a sub-analysis in the P53 mutated group, there was actually a clear advantage of adding bevacizumab. So it's something to consider in our practice, as well as antivascular agents in the frontline setting.
And I know you're going to talk, because P53 is becoming quite important, potentially guiding, encouragement, better prognosis for patients who've gotten chemotherapy, and potentially guiding adjuvant. So let's get to your talk, because I think it's going to be very relevant to our discussion. Take it away, Dr. Slomovitz.
I'm really excited about giving this aspect of the talk. I think it's, of the 4, obviously the most interesting, but I'm supposed to
Most well delivered.
And the most
Luckily, the
interesting
audience is
presenter.
all asleep.
Yeah, exactly.
It was the best talk and hasn't been given yet. No, I'm kidding. I'm joking. The reason why it's so interesting, because in a couple of hours, if the press releases transfer into positive data that's practice changing, we need to come up with different agents to treat this disease outside the first line. There's a tremendous unmet need. I said, if they're positive, I want to be careful because they embargoed till later on today. But if they're positive, we need to do that. So I'm going to talk about novel investigational agents. Wearing my GOG Partners hat, it's really my job to come up with a tremendous portfolio to help support this initiative. So first off, let me talk about exportin. Exportin is a nuclear export protein for tumor suppressor proteins, as listed for EIF4E bound proto-oncogenes. Elevated XPO expression inactivates the TSPs by mislocalization, enhances proto-oncogene translation, and correlates with a poor prognosis. Selinexor is an asset that we've been working closely with, and there's some data that I will share. It's an oral selective XPO inhibitor. It reactivates the tumor suppressor proteins and blocks proto-oncoprotein translation, blocks DNA damage repair. It synergizes with DNA damage-inducing therapies, and it's orally active. Here's a cartoon on the left showing the pathway with the inhibition. And this has been studied. We did an initial trial on this in all comers, all endometrial cancer patients, maintenance setting, the SIENDO trial led by our colleague Ignace Vergote with Dr. Vicky Macker, obviously a crucial part of the leadership of this trial as well, looking at selinexor in the maintenance therapy after a PR or CR to first-line chemotherapy in advanced or recurrent disease. Here are the results. In the ITT population, the various interpretation of results, but the ultimate interpretation by the regulatory authorities is this being a negative trial or not positive enough to pursue selinexor at this time for regulatory FDA approval. And you can see the numbers of median PFS selinexor of 5.7, placebo of 3.8, which was interesting to pursue. But what we did further on is to do a subgroup analysis, a pre-specified exploratory subgroup analysis of looking at P53 status. And this is this Kaplan-Meier curve shows the P53 wild type subgroup. Selinexor 13.7 months PFS, placebo 3.7. Very, very exciting, very interesting. Obviously an area that we think may change the standard of care. Because this is an exploratory endpoint, this was presented to the FDA. This is all in the public domain, and the FDA said we need to do a separate prospective study evaluating in the P53 wild type population the addition of selinexor in the maintenance setting. In this previous study, I just wanted to show here some of the treatment adverse events in the ITT population, and they're shown: increased risk of nausea, vomiting, constipation. Overall, well-tolerated, patients did well. Based on that conclusion, based on the fact that it may be exciting in the P53 wild type group, the GOG in partnership with NGOT and with the with Karyopharm, the sponsor here, is running a randomized phase 3 trial of oral selinexor. Same trials, but specifically in the P53 wild type group. As you mentioned, Shannon, one direction that we're going in this setting. This is the primary endpoint here is to evaluate the efficacy of selinexor compared to placebo as maintenance therapy. One direction that we're going in, and we may have to make some changes based on today's results to make sure that this is a robust trial and we can keep going. HRD, we've been talking about the role of PARP inhibition in this disease. One of the rationale is the high rate of HRD defects. We can see PTEN, BRCA mutations. They do exist in endometrial cancer. We're hoping that this will translate to a potential role of PARP inhibition in this disease. The presence of these molecular alterations were not prognostic for overall survival. PARP inhibition in uterine cancer is being actively investigated. There's some of the trials that are here that are looking at it. Just to point out to the Panosis trial, progression-free survival is 3.65 months there, and the post-trial also showed some activity. Moving IOs into the first line, I want to congratulate the leadership of Dr. Westin and her colleague Dr. Moore, and Dr. Powell and Dr. Mirza, who are running these two trials, Ruby Part 2. Ruby Part 1 is being presented today. Part 2 is incorporating their PARP agent in that setting, niraparib, and the DOE will, GOG 3041 will be adding olaparib to the regimen to see if it's active there. We've been talking about this a lot. As Shannon said, I think everyone on the stage is really interested in this pathway. Looking at HER2 amplification or overexpression in the uterine serous patients, we see a 17% rate of overexpression of uterine papillary serous patients. Targeted therapies, unique patient-specific therapies. We're not saying for all patients, but in a subgroup of patients. Uterine sarcomas, HER2 expression 16%. Again, an interesting group that we should be looking at. Here's some of the IHC and FISH characterizations of endometrial cancers. I don't want to dive into this too much, but this is sort of the way while we're evaluating it. One-liner, IHC 3+ positive, I consider it positive. It's 2+ by IHC. I go forward with the FISH analysis for amplification. This was mentioned, I don't want to spend time here. Amanda Nichols-Fader and her colleagues showed that addition of anti-HER2 trastuzumab with chemotherapy in the first line and the recurrent setting does have an advantage, probably more robust in the advanced stage setting, as shown by the middle Kaplan-Meier curve here. That in itself is in the NCCN guidelines, but the NRG group led by group leader Dr. Powell here is coordinating GY0100026. And Britt Erickson is leading this trial, newly diagnosed patients, randomized to one of 3 arms, standard paclitaxel, carboplatin, arm 2 with trastuzumab, and arm 3 with trastuzumab and pertuzumab. Trials just getting going, but it will have important implications moving forward. ADCs and HER2 show some promising preliminary clinical activity. As demonstrated here, we see some activity in the carcinosarcoma population with a median PFS of 6.7. The HER2 population low, the 10 patients, is also showing activity. And I'll talk about that moving forward. We're also seeing some activity in all endometrial cancer patients. Very exciting. The Destiny trial, if you're not familiar with this, was positive in the breast cancer population, looking at HER2 expressing tumors, not just high, but low as well. This asset, this is an ADC trastuzumab, showed that trastuzumab in ADC in the setting met pre-specified endpoints for objective response and durable response across multiple HER2 expressing advanced solid tumors, and we're looking forward to more further results on this. Robert alluded to, it's not only the trastuzumab ADCs, but TROP and folate receptor alpha as well. Not ready for prime time, but more to come to that, particularly in the clinical trial setting in the near future. And we mentioned CTLA-4 and the lag contributions. mTOR pathway, as you know, this is something I'm very passionate about, and we were able to get everolimus and letrozole into the NCCN guidelines based on our phase 2 data that we're into the GOG Foundation. The difference here is not necessarily in the response, but in the progression-free survival. Really exciting data with NAB sirolimus. This has actually an FDA indication for PCOMAs, and we're going to further expand that into the endometrial cancer group, hopefully with studies in the near future. There's so much information, but I'll leave it at that to make sure we stay on time.
Okay, perfect. So thank you to all the speakers. These are just amazing talks. And we do have just a few moments for questions that have come in from the audience. And so I'm going to try to get to as many as I can. But I think this is really relevant to what you were just talking about, Dr. Slomovitz, this whole idea of platinum-free interval in endometrial cancer. So how much data do we have on that? We're seeing, our trials are saying you can either be after 6 months, you can be after 12 months. What is the relevance of that? How do we use that to guide therapy for our patients?
Yeah, just a quick story. I can tell you how uncertain we are of the answer. We on the same day, we talked about two different studies when we devised Ruby, and when we came up with DUOE the same day. In the morning, we said 6 months. In the afternoon,
Yeah, exactly.
So the same day, we don't even know what's going on. It wasn't even a couple months later.
Exactly right.
Remember, it was crazy, but it was in New Jersey, so strange things happen in New Jersey. There's no such thing as platinum sensitivity resistance in this setting. We need to further define it.
Right.
But as alluded, without options, personally, like the case that was presented earlier, 11-month disease-free interval, I'll go back at it with the carboplatin paclitaxel.
Yeah.
I mean, it's reasonable. But we don't have any great data.
Yeah, and then I'm just going to cover one more question that came up a couple of different times, was this idea of when you do have an adverse event that's related to the lenvatinib, what do you do? And so, we talked about holding the dose. You want to give them some time to recuperate, and then you want to restart, but you're going to go down on your dose. We don't know the right answer. Should you start at a priming dose? Should you start at that 20 milligram dose to be able to get that activity that Dr. Slomovitz was talking about? Or could you start at that medium level dose? We just don't have those data, so I think a lot of us do try to start at that max dose and give yourself that wiggle room to go ahead with a dose interruption and then a dose reduction. And with that, I just want to again thank our speakers. They were all amazing.
Thank you.
And then, of course, I want to thank our contributing physicians, the community physicians that gave us these amazing cases that we could discuss, and then thank all of you for attending. So just again, thank you so much for your attention, and have a great rest of your meeting.